anticipating any updates or?
I think we should be ready to go. Yeah, I'm just gonna do one pass outside to see if there's any other people in the hallway to join, but I think we're good to go with introductions and all.
Okay. So I'm so sorry that I'm not there with you all, and I don't know if there are any people there in person, but Zoom is somewhat impersonal, but at least we find a way to connect. So I'm gonna unshare my screen for just a second and then just do some introductions with you all. So I'm Dr. Ramya Ramaswami. I'm a physician scientist and researcher in the HIV and AIDS malignancy branch at the National Cancer Institute at the NIH. I see a couple of people here, and I just want to give you all a chance to introduce yourselves if you'd like to do so.
Oh, Phyllis Cohen. I'm in Houston, but I've been up at NIH before.
Yes, you have.
At
We've
least
met
not
in
that long
person.
ago. Not that long ago, really.
Yeah. I see someone else online.
Somebody with a K. Kent.
Yeah, I'm Kat.
Hello.
I'm in Canada.
Nice to meet you. And I see Chris there. Hello, Chris.
Hello, Dr. Ramaswamy.
Sorry we didn't get to see each other in person this time.
No worries.
All right, so I think if without further ado, let me just share my screen and we'll get started. So, all right. So today I'm here to give you a few updates from I know Dr. Lorraine, my colleague from our group, has been speaking to you once a year to update you on developments, and I just want to be a resource to you all and provide you with some insights on management of this condition that we all know and think about often with HHV-8 associated Castleman disease, and look at the treatments that are available, the research, and then some of the symptom management points as well that I'm sure many of you are familiar with. And certainly I want to use this opportunity to just have a somewhat informal setting. And if there are questions during my talk, please feel free to interrupt and raise any points that you think are pertinent to your journey with this condition. So we're going to talk a little bit about the symptoms and diagnosis, talk a bit about treatment, living with Castleman's from our perspective, but also talk a little bit about the research and as well as, when Castleman's can come back, especially among our patients, as well as some of the other conditions that can happen in tandem with Castleman's in our population. So I just want to make sure that we're clear on that, and questions that come up with that specifically, please feel free to reach out about. So, as many of you know, given that multicentric Castleman disease is a condition that's sort of very different and has it's an umbrella term for different conditions that are associated with it. But HHV-8 or Kaposi sarcoma herpes virus associated Castleman's is somewhat slightly different. We think of it as a lymphoproliferative B cell disorder. So it's of the immune cells, specifically the B cells, and tends to happen with our lymph glands that are thought to be sort of the police officers and surveyors of things that are going on in our bodies. And so this type of Castleman's really affects those specific areas and is caused by a virus which is different from other forms of Castleman's. So HHV-8 or Kaposi sarcoma herpes virus, KSHV, as you'll hear me refer to it as, is a virus that's part of the herpes virus family. So Epstein-Barr virus is another one that people might be more familiar with. It is the cause of mono, and so HHV-8 and KSHV are sort of the sister virus of EBV. And most commonly we see this type of Castleman's among people with HIV, but over time and as we're learning more about this condition, we have seen quite a few people without HIV who also have this type of Castleman's. So we do see a spectrum, and we are more conscious that in people without HIV who have Castleman's, there may also be some underlying immune condition that might be driving them to have Castleman's. So one thing to be mindful of, which again is a little bit different from other forms of Castleman's, multicentric Castleman's, is that this virus can also cause other conditions that are separate from MCD. So as I mentioned earlier, MCD affects the lymph glands, but this virus can infect any type of cell. And one of the types of cells that it can infect are endothelial cells. So these are cells that are often in our skin. They line most of our organs. So you find endothelial cells also in the gut and in the lung. And so Kaposi sarcoma is typically the condition that is most commonly associated with this virus, HHV-8. So we often see our patients who have MCD with KS. The third condition, which is more distinct as well from MCD and KS, is a type of lymphoma. So this is a type of cancer that is involving the B cells again, but is different from MCD because all those B cells that are infected by HHV-8 and cause lymphoma are the same. So we call it a monoclonal process because those are lymphoma cells. All those cells are the same. With Castleman's, they're called polyclonal. So that means that the B cells, even though they're all infected by the virus, they're quite different from each other, and it is not typically thought of as a cancer. PEL, or primary fusion lymphoma, is distinct because it's a type of lymphoma and a type of cancer of B cells. The thing to remember with all three conditions is that we are trying to get people in remission a lot of the time. In PEL, it is treated with curative intent. KS and multicentric Castleman disease can come and go, partly because we know that there is currently no vaccine to cure individuals of the virus that causes these conditions. There's no vaccine for HHV-8. We are all hoping that there's one that might be in development. But pending that, because we cannot eradicate the virus, a lot of these conditions can go away and come back. Because PEL is a type of cancer, the treatment for lymphomas are with curative intent. But again, we do see patients in our group who have had multicentric Castleman disease and PEL, and sometimes the MCD goes away, and then the PEL can come back. So these are three conditions just to be mindful of as we encounter Castleman's. When we see patients with Castleman's who come to our clinic, oftentimes they have had a history of fevers and night sweats. They may have had a lot of weight loss, and it's common to experience that in the months preceding the onset of Castleman's. People can feel very tired and fatigued with these symptoms. Swelling is very common, especially in the lower part of the legs, as you can see on the right here. But also you can see swelling in other parts of the body, particularly abdomen. This is because there can be swelling of the liver and spleen, and that can cause a lot of discomfort and pushing of the abdominal wall forward. People can also have lung or GI trouble, and sometimes we're very mindful because, as I mentioned earlier, KS can affect the cells that are in these organs. Often when we see individuals having respiratory or GI symptoms, we often will investigate to make sure that there is no Kaposi sarcoma. Because again, if we do identify any of these conditions, we can treat them. And I think it's important when someone is diagnosed with Castleman's that we are looking for the other conditions that are caused by HHV-8 in order to treat patients appropriately. So what we often see, in addition to the symptoms, can be lab abnormalities. These can include blood counts. So typically we see a low hemoglobin, and this can contribute to the symptoms of fatigue and tiredness. We can also see low protein levels. This is the albumin levels in the blood, and this can often contribute to the swelling. I think of when we think of albumin and protein, they're sort of the rocks that are in our bodies to kind of keep the fluid in the right place. So rocks in a riverbed is what I sort of think of them as. And when you take the rocks out of the riverbed, the water can sometimes go into the wrong spaces. So you need protein to be in your body, and the albumin in your body sort of keeps the fluid in the right places. And so when we see low albumin, that can certainly mean that the fluid is not able to get back to the heart, and it goes into tissue areas that can often be problematic and contribute to symptoms. We may also see low sodium. This can get very low and can sometimes be very concerning. So we keep monitoring that and ensuring that fluids are repleted appropriately. The most common and sometimes challenging part of Castleman's, as I'm sure many of you know, is that it can mimic other things like infection. So doctors, when you speak to them and you tell them, well, my C-reactive protein is up, it's quite a non-specific marker and can sometimes be an indication of infection, as can an ESR. But the problem is that because it's non-specific, we cannot always think that it's associated with Castleman's, and it's really the constellation of symptoms and lab findings, as well as the viral levels in the blood, that help us be more informed as to whether the symptoms and side effects that you're experiencing are related to Castleman's themselves. And this can be challenging because a lot of our patients can be admitted to the hospital repeatedly. And because Castleman's can come and go sometimes on its own without us really doing anything, what that can mean is that a doctor may have seen an increased CRP and thought, hey, could this be an infection, started treatment for that infection, and then people sort of get better. And then that association between the CRP and antibiotics can sometimes mean that, could there have been a Castleman's flare that has been missed? So typically what we sometimes see is that even though someone comes in with a Castleman's flare and we've confirmed that flare, and the diagnosis of Castleman's, what we look to see when we look back in time is that, someone may have had repeated hospitalizations because people thought they had infection. So this is often very challenging and can actually sow a lot of distrust between patients, their loved ones, and clinical care, because coming in and out of the hospital every 6 to 10 months, not really knowing what's going on, being treated for an infection, does sow some distress, and it is a challenge coming up to a diagnosis of Castleman's. The diagnosis, as I've mentioned, can be very difficult itself, and because the symptoms can be other things, patients have seen a lot of doctors before they come to us, and they've had a lot of imaging, and again, it's only when you take a little piece of lymph node and you're able to completely diagnose it that you're able to fully be certain that this is Castleman's. And so if you are, or your loved ones are suspecting someone who's coming in and out of hospital, has those findings, has those symptoms, it's important to make sure that your doctor's aware of, could this be Castleman's? And looking for the virus in the blood is a good way. But some of these image findings are also very typical of Castleman's, and I'll go through some of this imaging here. So on the left-hand side, you have a CT scan, and what we can see, the black areas are air, so these are lungs, and we can see that the lungs are quite clear. On the right here, you see the liver, which is quite significantly enlarged, and we see that in Castleman's, which is HHV-8 associated, partly because the liver and spleen on the left here are congested and upset because of the inflammation driven by the virus. On the right here, you can see a PET scan, and the areas that are lighting up are areas of increased cell turnover. So your brain and your heart are expected to have high cell turnover. We see the kidneys being outlined here because that's how the tracer gets out of the system. So you can see the bladder and the tracer, which is the dye that we use to highlight these areas. This is normal. So heart, kidneys, bladder, and we see the bases of the brain. Again, that's normal because that's expected to have high cell turnover. But everywhere else where you see white uptake, these are areas of high lymph node activity. And because the spleen is also a little bit more bright, and in combination with these imaging findings, we would start to think, well, okay, could this be Castleman's? And the imaging is very helpful to guide doctors into selecting a lymph node that can be used for biopsy. So, for example, if I was looking at this PET scan, I would probably take one of these axillary lymph nodes, and usually a needle biopsy, something called a core lymph node biopsy, that's the name of the procedure, should be used to diagnose Castleman's. It's also important to ensure that the pathologists looking at these samples are also well informed about what to look for, especially as this condition can be rare, as many of you know. Ensuring that people who are at the, looking down the microscope have a good idea of what they're looking for is also important, particularly because of the rarity. So I just want to pause if there are any questions so far on symptoms and diagnosis. Okay. With regards to treatment, and I'm sure many of you know about this, rituximab is a drug that we use in this type of Castleman's, KSHV associated. It's often the first line of treatment, and it targets a type of B cell, it's CD20. It's sort of, if you think about mailboxes on cells, rituximab is sort of able to deliver its target to CD20 positive B cells. And these are cells that we presume are infected by the virus and contributing to the symptoms and lab abnormalities. And it's incredibly effective in a lot of patients with Castleman's. And in about 80 to 90% of cases, rituximab that's given weekly for 4 weeks should be sufficient to treat Castleman's. In people with HIV, we hope and expect that they have access to the antiretroviral therapy, and we ensure that individuals with HIV are getting access to their ART during the course of their treatment. Rituximab has been given to millions of patients. It's extremely well tolerated. Usually the first time you receive it, though, there can be some side effects, particularly with reactions to the medication. So oftentimes it's given very slowly the first time you receive it. And if there are no immediate side effects, usually patients will receive it quicker, within 90 minutes, for subsequent infusions. It's really important to make sure that if you're getting rituximab, that you have hepatitis tested for, because sometimes this medication is known to cause reactivation of other viruses, and one of those is hepatitis B. So ensuring that, you and your doctor discuss that, if you make sure that you've been vaccinated for Hep B. But that being said, if you have not had a vaccine for Hep B, and if that's of concern, there are medications that can be started to prevent reactivation of hepatitis B during the treatment. So, as I mentioned, with rituximab, it's given 4 times, and it's as weekly doses. And we often only give it when someone's symptomatic with Castleman's. There have been studies looking at whether rituximab should be given as a maintenance. But the reality is, given that these medications do have side effects, and long-term use may not be beneficial, we only really give it when someone is symptomatic. So even if your HHV-8 levels were slightly elevated in the blood, if you had no symptoms, I probably wouldn't rush into giving you rituximab, because the risk and benefit of giving this drug, the benefit is really when someone is symptomatic from their Castleman's. If you had, or your loved one had, KS with their Castleman's, we would give rituximab every week for 4 doses. And because rituximab is known to make KS a little worse, we often give liposomal doxorubicin, which is a standard drug for KS, in tandem with rituximab, and that's given every 3 weeks. What tends to happen is the liposomal doxorubicin is continued beyond the rituximab for several months beyond. And that's until the KS is much better. So we've talked a little bit about the infusion reactions and ensuring that hepatitis testing is done. We know that because rituximab can deplete the B cells, and B cells are known for helping us ensure there's immunity with vaccination, that if you've been recently vaccinated for COVID-19 or other vaccines, oftentimes it can actually reduce the efficacy. So again, if you've not been vaccinated for hepatitis B, that's something we should discuss, but could be done after the rituximab infusion, because it takes about 3 months for your B cells to come back. And that's something that your doctor will monitor as well. And the liposomal doxorubicin is pretty well tolerated, does not make you lose your hair. It does cause low blood counts if that's given quite frequently, and it can cause some peeling of the hands and feet, but often can be well managed by reducing the dose or increasing the spacing between doses. So in terms of MCD and COVID as well, I know we're sort of in a slightly different era with COVID now, but usually we would still advise that, that all your vaccines are up to date, and monitor your symptoms and things over the course of following rituximab, especially as I mentioned earlier. It can deplete your B cells and make you more at risk for viral infections like COVID-19. Any questions on any of the treatment aspects just before we move on? Okay. So I think the main takeaway, if there's any message that I can provide you all today, is to really try and reassure you that although Castleman's, that's HHV-8 type, is quite rare, we know that people respond really well to the treatments, and that, administration of rituximab has really helped patients with this condition. And in a study from our group, and this was in about 62 patients with Castleman's, we looked at those who had had either Castleman's alone, Castleman's with KS, or Castleman's with PEL. And what we found is that the 5-year survival, at least because we had participants in our group since 2004. So when this was published in 2021, we had over 10 years worth of information, but we know that the survival is excellent in this group. And the real limitation really is having lymphoma. So in patients who have had prior Castlemans, if they get subsequent flares of their Castlemans, we're often very mindful in our group of looking for lymphoma because that can really affect survival. But again, just to reiterate, our intent when we treat someone with lymphoma is for cure. And so we are, every year making strides in improving the outcomes for patients with PEL, and we do have patients with lymphoma who are, survivors of this condition for a long time. So there are several treatment options. And it's also important to note having KS with Castleman's doesn't actually impact the survival. And this is important because, thinking about how this virus can cause other conditions in tandem, it can also cause a lot of distress, especially because KS is such a visual condition. It's important to remind you all that having KS with Castleman's doesn't actually change the survival outcome, and it's as good as having, the survival outcomes is as good as having Castleman's alone. So in terms of just a few reminders about what we can all do after receiving a Castleman's diagnosis, that of HHV-8 positivity, is really look for individuals who are experienced with treating this condition. Secondly, think about and find out what other conditions associated with the virus you may have with the Castleman's. So again, if you have Castleman's, do you have KS as well? Could there be a possibility that there's a diagnosis of lymphoma? And those are questions that we certainly keep in mind when we meet someone who's been newly diagnosed with Castleman's. Monitoring your symptoms and the treatment over time is extremely important, and I know a lot of you do journal how you do with symptoms and side effects of treatment, and that's really helpful and important in the partnership you have with your doctor and ensuring that treatment is successful. Especially because we know that Castleman's is one that comes and goes. Being mindful of your symptoms and any concerning new symptoms you're having, and things that we should be mindful of as you're coming into a possible flare are important. Not necessarily that we can prevent flares from happening, but we can certainly monitor things. And we do have participants who come to see us in our clinical trials where we are monitoring symptoms and lab findings, and hopefully with the research that we're doing, we may one day be able to prevent subsequent Castleman's flares as we go on. So as I mentioned, the monitoring really is symptoms. Fevers and night sweats are often the first sort of signs that something might be awry. Feeling lymph nodes, we have participants who come to our clinic who've been monitoring, say, a neck node that they feel is a little bit, getting a little bit bigger over time. We don't want to get to a point where there may be poor appetite or significant weight loss, but those are certainly symptoms that we often are very concerned about and are indicators of something awry with the immune system. Swelling can happen, but in someone with Kaposi sarcoma, that is also pretty common, something to monitor. And then any new rashes, this is something that people may not always think about, but rashes are, again, somewhat nonspecific, but we've seen when patients have Castleman's that they do have unusual itchy rashes on the skin. In terms of symptom management, it's quite often, again, because of the spleen and the liver enlargement, that people can get a little bit of nausea And so giving medications to prevent nausea, managing pain, thinking about any antivirals that we might need to start are important. Castleman's affects not only the body, but can actually have a significant impact on mental health. So getting the holistic care that you need, talking to people about how you're doing, how you're physically moving around, but also how you're coping mentally with your diagnosis is important. A moment to talk a little bit about lab values, and this is something that's certainly important as we think about, given that Castlemans can come and go, this can be a way that we can manage and sort of think about whether we are anticipating a flare. Usually, as we've talked about earlier, we do see low hemoglobin, low platelets. Those are cells. So hemoglobin, the compound that sort of carries oxygen around the body. Platelets are cells that help us clot when we get a cut. They're usually the cells that help us form a scab. Albumin and the C-reactive protein, and those are 4 markers that we use to look at treatment response. Usually they tend to be awry when you first have a flare, and they get better usually by the 3rd dose of rituximab. And these 4 markers are also the markers that we use to monitor in case there are other flares that we're predicting in the future. So these are those 4 markers. So just again, hemoglobin, platelets, albumin, and C-reactive protein are the 4 major ones that we monitor for. We also think about the HHV-8 levels, but those can sometimes be a little bit elevated without clearly indicating that someone's having a flare. So in the sort of hierarchy of things, I would say how you're feeling is probably the most important of imaging or lab values. And usually in my career as a physician, I don't think I've ever seen someone who feels terrible and their blood tests are perfectly normal. So usually how you're feeling is a real marker of what your blood tests and imaging findings are going to show. In terms of what happens with Castleman's if it comes back, I think the most important thing to tell you all is that if the Castleman were ever to come back, you could get rituximab again. And we know from our colleagues in the United Kingdom that even with a 2nd or 3rd course of rituximab, that treatment will be as successful as the first. The only scenario where that is not the case is if there is a diagnosis of lymphoma, because the treatment is so very different. So in patients who come to us and they've had a 3rd or 4th, flare, we're always mindful to look for lymphoma because that would change the treatment paradigm. We're also mindful that, rituximab is such a good drug, but we as a group of individuals at the NCI, we are looking for clinical trial options that can help our participants to prevent subsequent flares. So I know a few of you may have met or experienced multiple flares, those with multiple flares. And so looking for options where you don't have another flare again would be ideal. So I know it's hard with this diagnosis, but we do in our cohort of now almost 80 participants, some individuals have never had another flare and can go back to living a very normal lifestyle. And we do know that there are groups of individuals within our cohort who keep having MCD flares, and we're extremely sympathetic to the research that needs to be done to help these individuals particularly. Ensuring that all of us eat a healthy diet and exercise is important. Ensuring your mental health is addressed, and thinking about alternative therapies, but that's certainly one in this realm of rarity that should be discussed with your doctor, again, just to avoid any long-term complications and impact on your organs. And certainly, again, just to reiterate, we're here to provide the support that you need, given the journey to a Castleman's diagnosis is never easy, and then the stress and anxiety associated with flares and then subsequent flares is often very taxing on our patients. So certainly, thinking about long-term lifestyle adjustments, how having a diagnosis of MCD can affect work, family, sleep, as well as, having had a Castleman's flare and not being diagnosed or having delays in diagnosis can contribute to a lot of stress. So certainly ensuring that getting the appropriate mental health support is paramount. And certainly not having your mental health addressed can sometimes be a barrier to the journey overall. So we certainly support our patients getting the help that they need. So I want to talk for the next few minutes, just a few research updates from our group, just to hopefully see some of the light that we're doing, even in these times that we're all experiencing with budget cuts. But certainly, I'm sure some of you know that we have a study of a different monoclonal antibody than rituximab called daratumumab. So I talked a little bit about how rituximab affects the CD20 positive B cells. So this is slightly different because, interestingly, in Castleman's, the cells that are the sort of offending cells, the offending B cells or plasmablasts, they're actually not CD20 positive. So we think that the reason why rituximab helps is it sort of mops up B cells that are infected by the virus. And given the amount of virus in the blood is contributing to the symptoms and lab findings, we think that the rituximab sort of just getting rid of B cells that are infected with the virus. Whereas actually, when we look down the microscope and look at Castleman infected plasmablasts, we know a lot of them actually on their cell surface, their mailbox says CD38. So this study of daratumumab that's given once a week for 8 weeks, and it's just an injection, may actually work better potentially. So this is the question that we're asking in this clinical trial. This drug has actually been approved for multiple myeloma, so it's a different cancer. But we think it might work well in Castleman. So we have so far enrolled 5 participants with Castleman's, that's HHV-8-associated, and we've seen some benefit in about 4 of those participants. So we think it might be a potential viable option, but the trial is still ongoing. Certainly welcome any participants or anyone that might potentially benefit. Those who have had Castleman's before or those who've been newly diagnosed. Another study that we're currently running is actually an oral medication of a drug called pacritinib. This is actually also another drug that is licensed in a different a hematologic condition called myelodysplastic syndrome and myelofibrosis. So it's actually used in myelofibrosis, as an approved drug by the FDA. And we think it might work in Castleman's because as I've mentioned, the inflammation that we see in Castleman's is driven by the virus. It causes elevated interleukin-6, a protein that causes a lot of inflammation, and we think that upstream of that is actually the IL-6 levels are driven by aberrations in a pathway called the JAK pathway. And this drug may target components of the JAK pathway, JAK pathway, and it's an oral drug that is given twice a day. And the work done by my colleagues in the lab have shown that in these virus-infected B cells, the pacritinib actually led to a lot of cell death. And so we have launched this study, which is now open for use in people who have Castleman's with or without KS. But individuals, because this is a new drug and we know rituximab is beneficial in this part of the phase of the study, we are enrolling only those individuals with Castleman's who have had prior rituximab. We actually have one participant on it currently who's doing very well and is also getting some chemotherapy for their KS. This has been mentioned by Dr. Lorraine before, but I just want to emphasize that in our cohort of participants, we always are looking for better and newer ways to diagnose Castleman's, because we're very mindful that Castleman's can often be missed. Because if you think about, how unwell someone can be when they get diagnosed with Castleman's, and if their platelets are low, platelets help you clot. So sticking a needle in a lymph node when your platelets are low is often a contraindication, or, sometimes our patients are very unwell in the intensive care unit. And so doing a lymph node procedure might be really challenging. And so we worked with our colleagues, and also this was published from colleagues in France, looking at the fluid around the lungs, which can sometimes manifest in patients with Castleman's, but also looking in the blood to look at specific methods to diagnose Castleman's. And the way that's done is using a technique called flow cytometry, where the cells, there's light that passes through the cells, and the machine sort of is able to delineate those cells that are infected by the virus, HHV-8, and then you're able to look at the mailboxes on the cells and characterize, if these cells are HHV-8 infected and they're, say, CD38 positive, CD20 negative, those cells are characteristic of Castleman's. And so this can be done on fluid and blood. There aren't that many centers that do this because there's some skill set that's involved in looking at the cell types. But myself, my colleagues at the NCI, and certainly our colleagues in France are looking at ways that we can, sort of better package this method of diagnosing Castleman, so it's easier and much less invasive than the existing methods. So if in a case where, say, we have someone with suspected Castleman's and we can't do the lymph nodes, we are looking at these methods right now to diagnose them in place of doing lymph node biopsies. So again, I'm wrapping up here, and certainly very grateful to the CDCN network and the work that's done to help patients with Castleman's. And certainly we are here as a resource to you all for answering some of the research questions and helping to support you through this journey. And I'm happy to answer any questions that anyone may have. I'm going to unshare my screen so I can see faces again.
I have a question that's somewhat specific to me, but I'm HIV negative, but I also have KS and I have Castleman's, but I'm really fine, like all the time almost. But I don't take steroids but periodically I'll have some sort of orthopedic type injury and they'll want to give me a steroid shot for something. And I don't know whether that's also a no-no. I've just kind of wondering what your thoughts about that are.
Yeah, no, that's a brilliant question. I think we are certainly more reticent about systemic steroids, so oral steroids.
Yeah.
If it's a one-off sort of injection for knees, I think that's okay. But again, if you keep doing it, the repeated exposure can put you at risk. So
Okay.
if it's the same knee and you're getting it every, say, 3 months, it becomes somewhat problematic.
Okay. That's kind of what I mean. I've stayed away from them, but periodically you know, I would
Oh,
get a
who
recommendation
was it
for one.
that ordered your steroids?
I'm sorry. Can
So
you
I
hear that?
think, Phyllis, I think that's reasonable, but certainly no one would want you to suffer in silence if you're having terrible knee pain and needed a one-time injection. So I think
Yeah,
that's
well, I've mostly managed to address things a different way, but I've just wondered if it would be okay if I did it once or something. I mean, I'm
yeah,
not sure I
yeah.
will. I just kind of was wondering about your thoughts, but I guess what you're saying is it could still get into my system through that
It's
injection.
less likely with localized steroid administration, but it's the worser of the options is like systemic, having
Yeah,
long
right.
courses of higher doses of steroid.
Yeah, I
I
don't take them. Yeah,
Yeah, so
I don't take them at all.
I think you're safe. And then, it does happen that, we've had patients who've had one or two intra-articular injections and they've been fine. So if it's something that you and your doctor think, hey, we can do it, but let's monitor for things, I think that's reasonable.
Okay,
Mhm.
okay. All right. That was my question. I didn't want to forget it.
Yeah, of course. Any other questions at all? It's always being the person, it's hard being the person before lunch. So I want to make sure that everyone gets their time to get some lunch and carry on with the rest of your day. So I'm happy to answer if people were a bit shy, wanted to ask any questions, please feel free to email me. I think Madison and the team have my email. So please feel free to reach out and happy to answer questions. Okay. Well,
Thank you.
thank you for your time and all the best with the rest of the day. Take care,
All right.
everybody.
Thank you.
Bye.